Welcome to our Insight APSAD webinar for today, the 16th of June. I'm very pleased to be able to host today's seminar with you. My name is Irene Francisco, and we're welcomed by Pat Dudgeon. And before I introduce Pat, I would like to acknowledge the traditional owners of the lands on which we're meeting today. I'm here in Brisbane, Meanjin, on Turrbal and Yagara land, and I would like to welcome all the peoples of the First Nations who join us today and pay my respect to elders past, present and emerging. And I'd also like to acknowledge those people with a lived experience of substance use, mental health issues, those who've been affected by suicidality, and the loved ones, carers and support people who help them on their journey. I think that our acknowledgement kind of brings together two of the key issues that Pat will be addressing today, which is looking at the impact of colonisation, I guess, on suicide rates for our First Nations people, which we know are twice that of non-Indigenous Australians. So it's a big issue that faces all of us in all of our workplaces. So I'd like to welcome Pat and introduce her. Pat Dudgeon is from the Bardi people in Western Australia. She's a psychologist and professor at the School of Indigenous Studies at the University of Western Australia. And she's also the director of the Centre of Best Practice in Aboriginal and Torres Strait Islander Suicide Prevention. As a chief investigator of a national research project, generating Indigenous patient-centred, clinically and culturally capable models of mental health care. Pat's been widely published, particularly looking at social and emotional wellbeing and improving our understandings of models of practice and care for Aboriginal Torres Strait Islander people. So I'd like to welcome Pat, a massive big warm welcome to you. I'd also just like to remind everyone that if you have questions, to please post them in the chat as we go, and we'll be collating the questions at the end and having a chat with Pat right at the end. So feel free to add any questions as we go. So welcome, Pat. I'll hand over to you now.
Thank you, and it's a pleasure to be here and do this webinar, which I hope will be interactive. So do get your questions together, everyone. But before, I'll just, that was the acknowledgement of country. As I was introduced, I'd like to also acknowledge country. I live and work in beautiful Noongar country in Perth in Western Australia. So I'd like to acknowledge and pay respects to our traditional owners of the land we meet on today, all the different lands we're meeting on. I'd like to acknowledge all the elders, past, present and emerging, and acknowledge and respect the continuing culture, strength and resilience of all Aboriginal Torres Strait Islander peoples and communities. I'd like to also acknowledge all our allies across the country, and if you're not an ally and you're not interested in social change, you wouldn't be a part of this webinar. So welcome and acknowledging everyone. Before I start my presentation, which is largely about suicide prevention and some pretty good things that are happening, you know, we're starting to address some of the big problems, and also the grant that was mentioned. That's a long name of it. It's short name because we thought, oh, that's a big, you know, tongue-tying name. So we actually have changed our grant's name to Transforming Indigenous Mental Health and Wellbeing. So that's a NHMRC Million Minds Mission grant, which we hope will be able to make some significant change to the body of knowledge and also policy around Aboriginal Torres Strait Islander mental health. But I do need to start with a bit of a background, so I'll do that now. Basically, as most of you know, Aboriginal and Torres Strait Islander culture is rich and ancient. It's got a history up to 60 to 75,000 years ago. So it's a very old culture. You know, original theories of arrival have been disputed. It's recognised, Aboriginal culture is recognised as one of the oldest living cultures in the world. Colonisation occurred just over 200 years ago. And a lot of the issues that we see today are from the impact of colonisation, and I'll be talking about those in detail. But despite that history that had a profound effect on this country, I think the strength and resilience of peoples and the cultural reclamation that's happening now is really, really important. So Aboriginal and Torres Strait Islander culture is a very large, there's a large diversity of language groups and cultures, originally 250, more than 250 different language groups. We have good measurements on our disadvantage. And some of my Aboriginal colleagues say, you know, this is so deficit based, but I think it's good to measure things, to measure health or social indicators, because then we get an idea of the situation and what needs to be changed, where we can put resource, and what needs our attention. So I don't think any other Indigenous people are so well measured as we are, but it's not necessarily a bad thing. I think it gives us a good grasp on what needs to happen and where we need to make, the government needs to make investments. But basically, as you all know, the Australian population is 24 million people. Aboriginal Torres Strait Islander people are 3% of that. So the majority are Aboriginal, mainland Aboriginal people. I think there's about 90 to 95% of that population is Aboriginal. The Torres Strait Islander, which is a different cultural group, about 5%, plus there's 5% where with people with both Aboriginal and Torres Strait Islander cultural heritage. But basically, a lot of the measurements have shown that there's a lower life expectancy for Aboriginal Torres Strait Islander people. At one stage, I was involved in the Close the Gap campaign, and when that first started, the life expectancy difference was put at 17 years. So that's a big difference. That has been recalibrated, and it's now accepted that it's at least 10 years. So there's a lower life expectancy, and you know, that could be one of your questions, why, but I'm sure I'll answer it as I go through my presentation. There's lower average rates of income, there's less home ownership, lower rates of employment, and much lower rates of education. Death rates are higher across all age groups. So there's high rates of infant death, homicide death, arrest, imprisonment. You know, sometimes Aboriginal people are making up, you know, 70 to 90% of incarceration. So that's a big issue that's emerging as another big issue for us, is Indigenous people and the justice system. Infant death rates are 2 to 3 times that of other Australians. Homicide death rates 6 times higher. And something happened to my PowerPoint there. We'll just ignore that. With the big issue though for us and our focus of work is suicide prevention. And this is mainly, it is our suicide rates is twice that of the rest of the population. And I think you'll see later in my other slides, when you break it down geographically or by age group, it's an extreme difference. And this was not happening 30 years ago. I think a lot of, there's a lot of factors that contribute, and I'll address some of those as we go along. But basically it's due to, some is due to historical and political determinants for Aboriginal Australians. 6% of all deaths amongst Indigenous people. It's the cause, suicide is the cause of 6% of deaths amongst Indigenous people, compared to 2% with non-Indigenous populations. It's the second leading cause of death for Indigenous males, 10th for non-Indigenous. It's the 7th leading cause of death for Indigenous females, the 23rd cause for non-Indigenous. and it's 40% of all Indigenous youth deaths. So suicide makes up 40% of all our Indigenous youth deaths, and 23% of all suicides deaths in Australia, that's children aged from 5 to 17, are Indigenous. So, you know, one of the questions asked is, why is there a mental health and suicide gap? Well, for Aboriginal people, there's often multiple, frequent and severe exposure to stresses and adverse historical and social determinants. This weakens resilience, you know, and we know this from the measurements that have done through the Australian Bureau of Statistics. You know, we know too that through the measurements that have been collected in from the Australian Bureau of Statistics, that there's triple the average rates of high to and very high social, very high and very high psychological distress. So they've measured that. But we also know that there's a service gap. So there's significantly less access to culturally appropriate primary mental health care. There's institutionalised racism in the general population, mental health and suicide prevention services. So we have issues happening, but not the services always there that can address these or support people. There's untreated mental health problems, and these show up in stats as double the average rates of hospitalisation for mental health conditions, and obviously double the average rates of suicide. And these in turn contribute to alcohol and other drug use, violence and trauma, unemployment and poverty, imprisonment, community, family and cultural stress. So this is a bit of, we're trying to redo this this diagram, which is not very sophisticated, but we're trying to do it so it's circular, because it's all a bit of a catch-22. So this keeps things happening, and I think for us it's important to look at what will be circuit breakers in this. So so all those issues are happening, and then they compound and go around again. So these are some of the, and yeah, our work, our research and our activity has been about putting the circuit breakers in place. But with alcohol and drug use, because that is a focus of this webinar, the Kimberley region of Western Australia, where the suicide rate is 52% per 100,000 people. So it's 16 WA and 12 for Australian. It's known as one of the suicide hotspots. It has 3 times high emergency department attendance for self-harm than the rest of Western Australia. And the highest rates are from 15 to 19 and 20 to 24. So there's the highest rates of emergency department attendance. And 80% of all emergency department attendance for self-harm involved alcohol. So alcohol has a role there. And I guess that's it, whether it causes it or it would be people's life circumstances that lead them to misusing alcohol and other drugs. So for Western Australia, again, 22% of all ED presentations involved alcohol, 3% involved methamphetamine. So I'll just go on a little bit. If we look at the suicides rate statistics for youth and break it down over age group, as I mentioned before, you can see there that the ochre line is the Aboriginal rate, and the non-Indigenous rate is the dotted blue line. So Aboriginal youth are most at risk of suicide, especially males between 17 to 22 years old. So it's an extreme difference. Amongst 15 to 24-year-olds, the rates of intentional self-harm, suicide, are 5 times higher than non-Indigenous youth. So things are not good. if we look at it in a different way and break it down again in this graph, looking at Aboriginal Torres Strait Islander people being the blue bars and non-Indigenous being the red or ochre bars, again, there's higher rates in younger cohorts in Indigenous versus older cohorts in non-Indigenous. So you can see that there's higher rates for the younger ones, and it decreases, and non-Indigenous rates go up. So there's a different pattern. However, every suicide, you know, because we do research and work in this area, every suicide is unique and needs to be respected in its own right. We're Aboriginal, non-Aboriginal, whatever age they are. So, and I'm really pleased to see compassion starting to become part of the language that we use in policy documents. And we were very much engaged with Christine Morgan, the advisor to the Prime Minister, and her work in doing her consultations and putting a report to the Prime Minister. And many of those recommendations have been taken up in the recent budget, but the language used was compassion first and the centrality of lived experience. And that's a big sea change for how we as an entire society have approached suicide and mental health. So we're seeing a really good change happening. I think that, you know, this is part of it, you know, us owning what's happening in our society, not blaming the victim or not turning it into only clinical issues that sort of blame the victims as well. But often people and the media in particular ask me, you know, why is this elevated Aboriginal Torres Strait Islander suicide rates? And look, it's a complex matrix of different factors. You know, there's ongoing exposure to socioeconomic disadvantage, multiple psychological stresses. There's grief and loss from premature deaths, suicides in family, community members and friends. There's dislocation and the forced removal of children, mistreatment. You know, there's violence and interpersonal conflict, transgenerational trauma, you know, coming from the stolen generations. And there wouldn't be many families, Aboriginal families in Australia, that haven't had that experience in their family history of being part of the stolen generations. There's pervasive racism and discrimination at individual, institutional and system levels, and we see that being named up now. But that's all around us. There's particularly for some of our young people, there might be a loss of sense of purpose and meaning in life. And then there's poor health, physical and mental, and social emotional well-being and comorbidities. And as we spoke about earlier, there's an access gap to mental health services. So 34.5% of Indigenous people who reported those very high rates of psychological distress also experienced access problems to mental health service. So the issue would be, are there any culturally appropriate or culturally responsive mental health services available, and can people get to them? So that's the issue. So the picture is not a good one when we look at all the stats. We're not alone though, that needs to be noted. So this is not just an Australian Indigenous situation. In 2018, we hosted the second World Indigenous Suicide Prevention Conference here in Perth. So, and the first one had been done, delivered in New Zealand. So we hosted the second one in Perth, and the third one was supposed to happen last year in Canada, and they're doing it online this year. And then it'll move on. So different countries that make up Indigenous populations will have will take turns at hosting that conference. It was very important. We had an opportunity to bring together, you know, people from Canada, New Zealand. Obviously, the host country is the most represented, but Canada, the United States, and so on. But as we prepared for the conference, we tried to look at what was happening in other countries in regards to suicide prevention as well. And we actually published ourselves a little report, which we need to check the stats on, because we're not statisticians. So we've been talking to the Institute of Health and Welfare about doing a comparative look at across the world, across the globe, at Indigenous suicide prevention statistics. But if ours are twice the rate of the general population, we know that USA is over 1.5 times the national average. In New Zealand, they're 1.5 times the national average. In Canada, it looks like they're 3 times the national average. And Inuit communities have got very high rates. So we stopped trying to compare them. And there's some in the Sami people, they're another very vulnerable group. Their suicide rates are elevated compared to much more than the mainstream populations in Norway, Sweden, and Finland. So it's been a big issue. And we do have colleagues, Indigenous colleagues, who also are doing research in across the globe, and the change is happening. I think that these appalling statistics have been appalling, but they've also galvanized change, which I'll go to now. But that little report, we ensured that Indigenous people from those different countries contributed to this report. And I'll get a resource sheet, and we'll make sure that the link to that little report is there. We do need to do much more work. And even though that there has been, we sometimes say there's too much measurement of Indigenous things, Indigenous, conditions. It's at least we've got them on hand. Not all countries do the same rigorous measurements as Australia does. In any case, when Indigenous suicides, became the big issue that they are, all the government asked us if, they said, what should we do? How should we fund Indigenous suicide prevention? And that actually instigated the solutions that work, what the evidence in our people tell us. So we call it the Atsipat report. So we started a significant project looking at that. And we knew that Indigenous suicide has very many causes, including cultural, historical, political, and other unknown considerations. So we need to look at the development of an evidence base about what works in Aboriginal Torres Strait Islander suicide prevention. Basically, I'm probably going to repeat myself, but basically, Atsipat, we convened the project. We worked with Telethon Kids Institute, and we did a very comprehensive literature review of both Australian and international literature. We did a huge review of programs, particularly programs that had been evaluated, to try and figure out what were the things that worked in different programs. And then we started a consultation process. Now we're we get a bit cautious about doing consultation, because one of the catch cries we hear is that Aboriginal people say, we get consulted and researched, to death, and then nothing changes. So we tentatively went out, but people were really happy to come to workshops to discuss their issues with the hope that things would change, and they have changed. So I'm really pleased about that. So we did a 12 round tables, workshops across the country. We also held the first ever national Aboriginal Torres Strait Islander suicide prevention conference in Alice Springs, and that actually, that was a unique and great conference, and that contributed to our report as well. We generated lots of tools and resources for Indigenous communities, for other stakeholders, government organisations, primary health networks to support Indigenous suicide activity. An evaluation tool was created or developed for evaluating proposals for Indigenous suicide activity. A community tool was developed to support the development of Indigenous suicide prevention activity. An evaluation framework for Indigenous suicide was also developed. There were interactive maps showing Indigenous suicide numbers and rates by postcode. There were fact sheets and discussion papers. Basically, though, we concluded that there wasn't only one good way of looking at suicide prevention, that you needed to break it down into we use the public health model, that there was universal approaches that were more about building resilience and preventing and dealing with the factors that contribute to suicide. Then you needed programs that were focused towards at-risk groups. So they were young people, in particular LGBTIQ people. Then we needed indicators, so as for programs for at-risk individuals. So even though we're very much into community empowerment and that healing needs to happen in the community, we do not we would not say there's no place. There is a very strong place for clinical elements as well. So by by seeing the prevention, what needed to happen in prevention across these different elements was very useful. But there were common elements. What the big thing that emerged from Atsipat is there needs to be partnerships with community organisations, particularly the Aboriginal Community Controlled Health Service. There needs to be employment of community members and a peer workforce. There needs to be indicators for evaluation, cross-agency collaboration, good data collection and dissemination of learning. So that was important as well. So our overall message from the whole of the Atsipat project, which went for a year and a half, was that there need to be community control and empowerment. That's our big message all the way through. Every workshop I attend, meeting I have with Indigenous people, if we're not about Indigenous control, empowerment and governance, it won't work. So programs should be holistic, that Aboriginal Torres Strait Islander definitions of health need to be a part of it. They need to be sustainable, strength-based capacity building, and also there needs to be genuine partnerships. And we've seen lots of examples of that. There needs to be safe cultural delivery and innovation and evaluation. After Atsipat, we were fortunate to compete and win one of the government leadership projects that were tendered out at the time, and we were then able to continue the work of Atsipat within the Centre for Best Practice in Aboriginal Torres Strait Islander Suicide Prevention. So we position ourselves as one of the leading authorities on Indigenous suicide. Our work is about reducing the impact of suicide by promoting self-determination and respecting Indigenous culture. We do a lot of advocacy work. Our aims are to identify international and Australian research and put them onto our website. So I'll get to that later. But we have a number of clearinghouses, very small. They're quite small, but very useful. And we identify the need for and facilitate innovative research to support best practice. We promote and disseminate best practice through our clearinghouses, our website, and our conferences. So you'll be given the links to our website, which has just been updated. So we have worked with communities, clinicians, workforce, and funders. We have published clearinghouses of best practice. We have developed and are developing resources and reports to address key gaps. We contribute to the development of policy and practice. We're partners with the key sector organisations to increase influence and reach. And we speak, we also have a voice and encourage in other Indigenous voices about Indigenous suicide in public forums and the media. But basically, self-determination is required to prevent Indigenous suicide. Our main messages to the government, and we've been involved in the development of the most recent, which is about to be launched, the National Aboriginal Torres Strait Islander Suicide Prevention Strategy, which is a part of the Christine Morgan's report to the Prime Minister. So we also have advocated that Indigenous organisations is given preferred provider status, and it'll be Aboriginal organisations, particularly those in the community-controlled health sector. So that has been one of the big advocacy aims that we've been doing. Basically, our latest work has been to develop a manual of resources in Aboriginal and Torres Strait Islander suicide prevention. We're actually launching that manual in about 3 or 4 hours' time. So when we send our information to you, make sure by this evening you look at the manual online. And this is so we were gathering all the resources onto the centre's website, but people people were telling us, that's all well and good if you've got the time, but it'd be good to have it put into some information to be put into a package that we can easily access and then we can engage with. So hence the idea for the manual. So it was it's extensive consultation on different groups' resource needs. So basically we've sorted it out that there's 3 different user groups predominantly. That is our Indigenous communities, individuals, family and friends, elders and community organisations. So that's one group. There's also another group who are clinicians and frontline workers. They need to have access to resources as well. And then the third group is PHNs and other funders. So, so we are supporting people to do the work that they need to do. There's a bunch of videos, podcasts, poster resources, tutorials, and written guidance in the manual. And it was developed by and with Aboriginal people. So I'll skip over that. It will be, I'll go back, sorry. It will be online, so it'll be it's an organic resource. So as we offer it, we hope that the feedback will then grow the resource, and it'll become much more targeted on what people really need. So that we've been quite excited about that, and I'll just go over quickly our clinicians and frontline workers part of the manual. You're getting a sneak preview, everyone. So this is for clinicians, psychologists, psychiatrists, emergency department workers, etc. So we've tailored that, and the reason how we've gotten the information together is we actually had Zoom meetings with people from the different target groups, and they've actually told us what they need to know. So, you know, some of the topic areas are cultural understanding and respect, responding to crisis, staying, you know, self-care, promoting a resilience and preventing suicide, responding to after suicide, clinical checklists and toolkits. So some of that we've pulled together resources from, some are already there, it's just that we've pulled them together into one central point. And where there are gaps, we will produce the resources to fill them. So that's an example of some of the resources. I'm checking my time because I've still got a bit to do, and I did want to have a conversation as well. And another important issue that we've been doing, and sometimes I think, oh, you know, is this really serving a purpose? But you hear back from communities, or I've learned that this function, what we do in promoting best practice programs from an Indigenous viewpoint, has actually been a great resource for researchers. So they've been able to come to our clearinghouse and know that the programs that we put up as best practice are best practice from an Indigenous viewpoint. So we've recently galvanised and renewed our efforts to get communities, to tell communities to share their programs and have them recognised and celebrated. So our criteria for best practice programs and services is Indigenous ownership, community leadership, community consultation and co-design. So they should have these elements in them. If they started in a mainstream organisation and have been adapted, that's okay as well, as long as there's good Indigenous governance present as it's being offered, when it was adapted and being offered. Evaluation, cultural responsiveness and capacity building. So so that's a bit about our best practice programs and services. One of the big issues that go hand in hand with suicide, so when we talk about policies, we need to have strategic frameworks on suicide prevention, but we also these policies are not alone, and that's been good to see too, that the government, when they talk about one issue and the policy that's most relevant, they speak about other policies, strategies and frameworks that also need to be a part of that. And to me, this says that we're going towards breaking down some of those governmental silos. But in any case, for Indigenous suicide prevention, social emotional well-being and the National Strategic Framework for Aboriginal Torres Strait Islander people's mental health and social emotional well-being is very important, and it goes hand in hand with our suicide prevention plan. So we are also sit on the Guy Dewey board. The Guy Dewey board is a recently convened Indigenous leadership group that looks after mental health and suicide prevention, and they've been responsible for developing the suicide prevention plan that's nearly is finished, but also they will be refreshing and renewing the social emotional well-being, the SUB framework as we call it. So because one of our streams of research is about social emotional well-being, we held a big gathering at the University of Western Australia in March, at the end of March, and that was co-hosted by Nacho, us obviously, and Guy Dewey. So that brought together the community controlled health state affiliates from all across the country and researchers and policy makers. So it was a relatively small gathering, but very powerful. So we hope to see more happening so we can flesh out what's happening in particularly in AMSs, you know, what are you know, led by the AMSs obviously, but you know, what sorts of social emotional wellbeing services are they at each organisation delivering, you know, how can we come together to share information, what would a workforce look like, what would a paradigm look like. So we've done previous work in the area. So our work from on social emotional wellbeing comes from the Ways Forward report and the first strategic framework. So it was the Indigenous psychologists who brought together, they had a look at the SUV framework and brought all those elements together into a diagram, which has been very useful. We managed to pack it down. Obviously, like any model and diagram, it's not, the reality can be a bit more grey and overlapping than you know, cute diagrams, but it's been a useful way to understand what if we were to look at different paradigms and notions of mental health and personhood and what was important. So so the whole issue about self, you know, there's self, but it is about, you know, we have to acknowledge the impact of history, the impact of social determinants, historical determinants, political determinants, but for good SEWB programs, we need to be cognizant that, you know, it's a connection to our mind and body and our behaviours, but also the connections to family and kinship, to community, to culture, to country and land, and to our spirit and spirituality. So that is one of our fact sheets that we produced. Again, we'll ensure that there's a link there. But basically, I'm looking at my time. I only want to speak for 5 more minutes, so I'm going to race through this bit. But basically, I think Indigenous governance has become an accepted way of doing things. So really, you're going to see someone say, "Oh, let's develop a program and not include Indigenous people in that." Well, I'd hope not in any case, but Indigenous governance needs to happen at all different levels. So you know, there's national levels. That's why organisations like Guide Jury are important, because we've got people advising government at that very big level, which impacts on funding and how Indigenous communities are cared for and included. There's regional governance that needs to happen, Indigenous governance and services, and also when straight engaging with communities. So we do have a document on that. We did a number of workshops with funders 2 years ago. We did a round of national workshops to talk about how they could increase Indigenous governance and ensure that the programs they funded had strong Indigenous governance. So that report is there. But I guess that it sort of came from Atsipat, where one of the outcomes was the need for self-determination. And that means inclusion in an empowered way, Indigenous governance. But when we started doing Atsipat and the Centre for Best Practice, some of the funders were, you know, some didn't care, but many were committed, but they didn't know how to do it. Hence our paper on Indigenous governance and the workshops we held. But I'm happy to say that I feel that's becoming the urgency, or the need to educate people or have the dialogue is becoming a thing of the past. Like, we're seeing some really good relationships, co-design and projects happening. Basically, a little bit about the Transforming Indigenous Mental Health and Wellbeing grant. We've got a huge group involved. Our partners are very important. We have NACCHO, you know, so while we talk about Indigenous governance, co-design, inclusion, etc. We also walk our talk. So with our research from the very beginning, we involved Nacho. Guy Dewey's a part of that, the Aboriginal Health Council of Western Australia, the Healing Foundation, the Kimberley Aboriginal Medical Services, AMSANT, we're negotiating with them how we can do further research with them. So having those Indigenous and non-Indigenous partners were very important for us. And we're doing a number of different, I'll go back, we're doing a number of different little research projects. So some about, basically it's empowering access to services, empowering access to workforce, and empowering access to systems. And I'll go back again. So basically, I'm the chief slave of it all, but I lead the empowering access to services. And Helen Milroy, who's one of our leading Aboriginal psychiatrists, leads Stream 3, which is looking at services and doing a lot of different research activities in there, but also looking at the role of traditional healers in mental health services. Jill Milroy leads the second stream, which looks at workforce, and we're doing some very good projects in that. And I won't go on about them. I sort of feel like talking more, but I'm going to finish so we can have a conversation, and we will send a sheet of resources with links to all these reports that I spoke about, but also our website, so you can go and have a squizzy yourself. But what's happening now? Guy Dewey is leading the Aboriginal Torres Strait Islander Suicide Prevention Plan, and the SUB framework is about to be refreshed and renewed. So the first one's coming to a close now. The second one's about to start. I'm seeing quite a big change happening nationally, and particularly in some of our states. Like our state in Western Australia has been working really well. They have an Aboriginal Advisory Committee to the Premier, but also when they started doing their suicide prevention, they actually tendered out the regional plans to local Aboriginal community organisations, and that's worked really well. And I'm very pleased to see that, because that's starting to support self-determination. So there's pockets of great change happening across the country, which are very augurs well for the future. So we're really happy to see that. Basically, you know, we do have Twitter accounts and engage in social media. So do consider following us. The Centre for Best Practice is a bit more of it tweets out a lot of information. Anything associated, we think associated, we'll tweet out. The Transforming Indigenous Mental Health and Wellbeing is more about our projects, which are just getting going. So do follow us for both of those. I spoke about the 2018 conferences. We had a national and a global conference back to back, and they were absolutely successful. They've become legends in their own lunchtime, these conferences, and people talk about how fantastic they were, because we ensured that there was great, we were coming together to talk about a very emotional and hard topic, and we were bringing communities in. We put a lot of our resources into ensuring that community members were attending, and so we also needed to support those people, and that those were important elements that made the conference a big success. And in Perth, we had over 550 delegates at the conference, and I believe that we took care of everyone. We had Indigenous psychologists, mental health counsellors, and so on. We had a lot of cultural activities. We had Ngangkari healers there to ensure that people were looked after and got a little bit of therapy. So it was a successful conference where people were able to come and be with each other to share their stories and information. And I'm really sad that Canada didn't happen as a face-to-face, and we didn't expect coronavirus. But possibly the next one, hopefully, will have vanquished COVID-19, and the next one will be face-to-face, because we were hoping to send some of our elders and our youth to Canada and to engage in that dialogue. So that will continue. But we had different focuses at the 2018 conference. We had a strong LGBTIQ stream. We had a strong youth stream. Data sovereignty was one of our other streams. And you can get this report off our website. Importantly, though, and Canada, the youth, they were fantastic. And Canada actually sent a delegation of youth across as well, which was really exciting for our youth. But in the youth stream, they developed a music video. It's only 3 minutes long, but they developed a music video to express themselves about suicide prevention. Obviously, there was help given, but I'd like to end my presentation with this 3-minute video, because I think for me it's about, empowerment of our more vulnerable groups within the bigger vulnerable group, and it is about us also walking our talk and giving our youth a place. And ensuring that they're at the table as well, and that they tell us what their needs are. We can't profess to know it. They need to be there engaging as well. And the third issue from the video is that it is strength-based. I think even though our people know sometimes things are really hard, they always turn towards hope.
Rivers flowing across my country, it's taking me back home. For as long as you feel love, for as long as you feel loved, the song is first raised, birds awake on, brings a fresh new day.
I sit in the night, the stars are bright, through the branches of the julga tree.
For as long as you feel love, for as long as you feel love.
Yeah. As long as you're feeling love, that's all that matters in the end of the day. I see so many people trying to fit in, but be yourself is the way. Never care what they say, stay on your grind, and everything will be okay. Shoot for the stars, forget all your troubles in the day. Keep your head full of hope and your heart full of love. Remember where you came from and who you are. Culture is everything, and culture is life. So when I'm rapping on the mic, I bring my culture to life. We all destined to rise, we weren't born to fall. So if you see a brother and sister down in the dumps, give a helping hand up and ask if they're okay. Cause no family should have to bury their loved ones on any given day.
That was such a beautiful way to end. And I'm going to get a little emotional.
It is, isn't it beautiful? I've
It is
watched
beautiful.
it so often, but I still love it. It's just so full of hope, isn't it?
Thank you. Yeah, as I was saying, that your presentation today was so full of hope. It's such a big topic, and it's been so distressing to so many people for so long. And to have you present in a way that makes us think, actually there are things that we can do, and there's hope. So thank you so much. We have got lots of questions. And I did also want to let you know there's been lots of feedback in the chat about the manual. So people are very excited by the resources that will be launched soon and are looking forward to accessing those.
And please, everyone, once you see it, give us feedback, because it's no point in us developing what we, think might work when we're not actually in your situation. So, give us feedback, because then, if we agree and whatnot, we can obviously shape those resources. So this is important for us, and it's a resource for Aboriginal communities and services, but it's a research for non-Indigenous people who are working with us too. So give us the feedback and engage in the manual. It will be launched today and will be available.
Excellent, thank you. And I guess that's a nice segue into some of our questions in terms of both support from Indigenous communities and organisations, as well as non-Indigenous clinical services, or those run by non-Indigenous organisations. So there's been a bit of discussion in the chat about earlier on in your conversation, in your presentation, you mentioned whether there are mental health services that are culturally responsive and culturally appropriate that are accessible by our First Nations people. And there's been a few comments in the chat that's been, for instance, in Victoria, there's a 6-month wait in some of those services. So just if you could potentially comment on what can be done to improve access to those services. And you mentioned the prioritising of funding to Indigenous services, but also what can be done from the point of view of non-Indigenous services, making those services more acceptable to Aboriginal Torres Strait Islander people.
Okay, look, first thing I'd do is to get to know the local community and the other services that are close by or in your area of the service that you offer. So, make a relationship with the, if there's a local, particularly a local AMS there, or a healing centre or whatever. So to build lateral relationships is important. Say that you're here, that you want to be able to offer a culturally responsive service. They may also be your advisors, but to build that relationship, then they might also refer their clients on. And so that's important. Not, I think if a new service comes along, for instance, and they're not talking to the local Aboriginal services, it's rude. So to ensure that you do develop a relationship, that you're not cutting across someone else's lawn, but you're working together, that's important. And to ensure that your staff, you might consider, there's lots of little things you could do. Has your service got a reconciliation action plan? Consider doing that. consider sending your staff to do a cultural responsiveness training. So there's many cultural responsiveness training, or led by Aboriginal people, though, obviously. So consider getting cultural responsiveness training. Consider your officers, and you know, do you fly the Aboriginal flag? If not, consider that. Consider having some Aboriginal posters up. I live too far away from my local AMS, so I go to a clinic that's closer. But I love that they've got some Aboriginal posters up. That makes me feel more comfortable. When I hear an acknowledgement of country, when I go to a meeting, and particularly when I'm the only Aboriginal person there, that makes me feel comfortable and valued too, you know, that my people are valued. And we are coming out and still living in a society that has really marginalised and devalued us, you know, racism. So that's what I'd advise. Look, there's lots that can be done, but you know, trying to engage, ensuring there's Aboriginal people on your boards and committees, that's another one. So in the Indigenous governance report, which is probably getting outdated, even though it was only produced, you know, about three years ago, there's lots of advice and information as well, but we certainly will update that, because I think that's important for us to capture, is that there has been a change, and people are keen to be a part of the solution, you know, not the problem. So we'll do everything we can to support that.
Awesome. And I guess leading on to that, there's I guess concern around that building capacity. So Indigenous organisations building enough capacity to be able to meet the need, but at the same time mainstream or non-Indigenous organisations and services who may also have gone through cultural awareness training and have that quite strongly embedded, but feeling that they might not be able to sort of fit into the political landscape and the funding landscape for services to meet this quite large need. So I guess the comment in here is that some organisations, like, what support is there that we can do so that the services can work together? And I think you've touched on it a bit, but if there's anything else, particularly around funding or service collaboration, that you might want to elaborate on.
Well, I think it'd be okay to approach an Aboriginal organisation if you know, you wanted to look at you know, starting to offer services for Aboriginal people, and to say, you know, we'd be keen, do you think it's a good idea? And then how can we do it with your support? How can you support us, but we support you and capacity build you? So in saying that, you know, you know, we know that, for instance, we're NACCHO, CAMS, and all the Aboriginal providers, stakeholders who are part of our grant, they are important to be a part of our grant. But we know we also have to capacity build or support them. So I can't go, I don't think, get Aboriginal people involved, but also pay when you need to. So people think, oh, I'll get that Aboriginal person to do this workshop for me or be on my boards and committees, and it's all for free. But there has to be a reciprocal transfer happening too. So it's how you support, and asks, how can we support you?
Lovely, thank you. One of our participants is curious about the indicators for evaluation of the programs that you're rolling out. What are the ways in which you're going to be evaluating?
Oh, well, we personally don't do any evaluation. We've just done but the programs, we obviously best practice programs and services, we prefer if they're evaluated. We do provide Aboriginal communities with a number of what we consider good evaluators are. So ones that we've vouched for, and we're building that repository as well. But I think that for us intellectually or academically, we've just done a paper with the Institute of Health and Welfare talking about, you know, we know that there's different ways of evaluating programs or services or models. And so sometimes mainstream criteria actually dismisses Indigenous values and aspirations. So we've been having a dialogue on you know, what is evidence-based, and talking about practice-based evidence rather than clinical evidence, or as well as, you know, I don't like to dichotomize. It's we don't like to throw out the baby with the bathwater, but so looking at different criteria is important as well, and valuing that works for Aboriginal people. I don't know, that's a fuzzy way of answering that question, but that'll I
guess and some of this is, I mean, it is complex, isn't it? So it's not always just a clear cut answer. This one might be a bit easier to be a clear-cut answer, but other resources that you're about to launch, are they being formatted for schools or for young people, given the big difference in youth suicide rates?
No, it is for over 18s. We have been working with Culture is Life, which is another Aboriginal organisation, and they have youth ambassadors. And so we actually worked with them, and over 20 youth were consulted on what they thought needed to be in such a resource. So that was important for us. We once we've launched the manual, we're about to do some more different streams of work, but we're actually going to formally engage with the Indigenous youth and go through ethics approval to start finding out what exactly do youth need. So that's a big issue that's taking off all around the country. In the Kimberley, they were one of the Commonwealth suicide prevention trial sites, and they've actually got their Empowered Young Leaders group happening there. So I think we're seeing youth come forward in a very strong way. They're being supported, and they're now at the table. So they're not just, and you know, they said, I went to one meeting where they said, you know, don't just bring us in like tokens, we want to be there and part of the decision making as well. And we're going, oh, okay. Then they kicked us out of us oldies out of the meeting because they wanted to do their business, which we were very happy about. So that's a new thing, and I think that's happening for both Indigenous and non-Indigenous. The importance of lived experience, whether it's in suicide or in youth, because I have gone to other workshops where, you know, we were talking about Aboriginal youth issues and there were no youth there. Mind you, that's going back about 5 years now, but that wouldn't happen now. So and we want to actually support that and do more work there. So we haven't gone under school age. I think we probably need to go there, or to work with researchers, good researchers who are already looking at children and their needs. So we've stayed 18 or above, but we do need to do that.
And I guess this is an opportunity for participants here today who work in the youth sector to try out the resources potentially and give you feedback.
Yeah, that would be great.
Yeah. Do you have any ideas of how we can infiltrate rural and remote, infiltrate sounds an interesting word, how we can get out there to the rural and remote Indigenous mobs with the project that you're launching?
Oh, look, one of the things, because I think we're committed to ensure that the manual has a long life and a really intense infiltration. So Julie Robotham, who's our senior consultant working on the resource manual, I expect her to take the manual and on a road tour. So she, after you know, she has her second vaccination, she'll start travelling and visiting both funders and Aboriginal community controlled organisations to see, you know, have they got any ideas? Do they know about it? Have they got any ideas? How can we improve and make our resources more targeted? What are the gaps? So those will be the questions, and going into rural and remote needs to be a part of that as well. So I don't know if she will be. I think there are some. We'll probably get Nacho's advice on how to approach rural and remote, but I do know that there's organisations like Sarah. I think they're still there. that look after that area. So we'll probably ask NACCHO their advice on how to go about doing that. But I think engagement in rural and remote, they're another vulnerable group too, with no resources there, eh? So we're very conscious of that.
Yeah, and I guess recognising the diversity of Aboriginal Torres Strait Islander communities across Australia. One of our participants has joined us from Townsville and has made the observation that over the past 6 months working in mental health, there's been lots of different services that have and projects that have been launched but haven't sort of continued or have fallen through. And the lack of sustainability in some programs does make it quite tricky. So wondering what your thoughts are on the matter of Indigenous community, not always being necessarily a unified community, and how that might create barriers, or what are some of the tips, I guess, for thinking about sustainability in our communities?
Look, I think that there are, no community is perfect, Indigenous, non-Indigenous, and some communities have more challenges, certainly. But I think that if there's good regional planning, that some of that can be overcome. So, we were part of supporting the Kimberley's suicide trial site. And initially when that was, and if you know about these trial sites, there were 12 Commonwealth suicide prevention trial sites delivered nationally, and they were well resourced in some ways. They got $1 million a year, and they went initially for 3 years, and then they were extended, and then in the most recent budget they have another year, not being called trial sites now, but to implement their programs. And I thought that was pretty powerful, looking at of empowering regions. So 2 were Aboriginal, one in Darwin and one in Broome, and the others took on different focus areas, if you like. But the Broome one, which we supported, when that all started happening, our primary health network actually did an amazing co-design with the Kimberley Aboriginal Medical Service. But then what needed to happen was to bring everyone to the table together. So that's quite a big group in the Kimberley, and there's lots of contesting priorities, and some people thought, oh, this is an opportunity to get funding for my program, and so the first year was settling all those differences. I think we can do them, or there's ways and means of bringing people into the room, but I don't think it's simple neither. I think that we need to work on building our communities so they can come together with a shared goal. I've seen it happen. I know in some places it mightn't happen at all. Maybe there's deep-seated community fractures or whatnot, but it can be done, and it's about how we get everyone to have a say in what's happening. So it might be that you do 2 lots of consultation, but I think if we're going for significant change and long-term change, doing community building exercises are very important.
And I guess that links in a little bit too in terms of community building, recognising and understanding the nature of suicide and the various factors you went through earlier on about how suicide can eventuate. One of the things that we do know is that exposure to suicide does increase the risk of suicidality in people, and in small communities or in tightly knit communities where there is a lot of suicide, that ongoing exposure to suicide is such a strong factor. How are the programs, or what programs do you see happening to help heal communities around that?
Any community, and I've just read the Cairns comment now. I shouldn't be looking at that, I get distracted. But yeah, no, the family wellbeing service is that with if they're the ones I'm thinking of, I think we've named them as best practice already. I think it's with the University of Queensland, but anyway, I won't distract myself, Pat. I think for in any community, again, Aboriginal or non-Aboriginal, there needs to be a smorgasbord of different services. So different people will need different services because we're all different, but also different times of our life or our journey. But I think what emerged, particularly from the Kimberley experiences, was the need for some healing to happen before we start the planning. So, you know, you've had people that have been just decimated, this ongoing racism. I was speaking to a non-Indigenous colleague who said that in his lifetime, in the 80s, he was working as a government official, and he went to an Aboriginal community where the nurse used to fire hose the Aboriginal clients out of the, you know, off the clinic veranda and just treat them like dogs, basically. So this is not that long ago, you know, and if you grow up seeing that, you know, your people being treated like that, you know, there needs to be a lot of community healing and empowerment that happens for our people, I feel. But you know, give people a chance of self-determination, and it does work. And so I think, I don't know if I've answered that question. I think there needs to be a number of services and programs available. I think the government is making an investment now, and I think it augurs well for all of us. But if you do have Aboriginal clients or work in an Aboriginal area, ensure that you're doing, and that goes for us too, you know, that we check our cultural responsiveness as well. So and I've given some tips on how to do that.